Okay, so for the next one in this series, we're going to do malignant tumors of the epidermis, and this corresponds to chapter 3 in the Elston textbook, and then there's also some information from the Olicon textbook. So same kind of thing. I'll show you the slide. You can think about it, you can pause it, and then I'll give you some hints, and then we'll go over what the answer is. So in this, you definitely have some lymphocytes present in the dermis, and you have some solar elastosis. But most of the action is happening in the epidermis. So you have crowding of the basal cell layer, but it's not full thickness atypia. And then you also have like some parakeratosis going on too. So this is an actinic keratosis. So this is just in the basal layer. It's not the full thickness of the epidermis. There's parakeratosis, there's solar elastosis usually present, showing that they've had sun damage because we know this is associated with sun damage. And then it spares the adnexal structures. So sometimes you see like a hair follicle or a sweat duct going through that is spared from this. And then there's a lot of different variants like hypertrophic, acantholytic, lichenoid, etc. So risk factors being older, male, fair skin, chronic sun exposure. It has to do with P53 mutations that leads to impaired apoptosis. So that's why you get the crowding at the basal cell layer. It's pretty low risk of transforming into SCC, but there is a risk of it. It's like 0.1% per year-ish. And then you can treat these with liquid nitrogen, 5-FU, PDT, some chemical peels, things like that. Okay, next one. So now instead of just seeing the atypia in the bottom third of the epidermis, we see it in the whole epidermis. There's some of these glassy pink cells. There's even like mitotic figures going on. Um, and like the cells basically aren't flattening out the way that they're supposed to as they go up. There's a lot of parakeratosis, but at the same time, it's not invading into the dermis. It's just staying in the epidermis. So this is Bowen's disease or squamous cell carcinoma in situ. So this is when you have full thickness atypia. Like if you flipped it upside down, you wouldn't be able to tell which side was up, which side was down. Um, and then the atypical cells may be like intraepidermal buckshot or nested pattern too. So like you can have pagetoid Bowen's disease, which would kind of look like that. And then it can come from an AK or just on its own. Risk factors are pretty similar to that of an AK, but also HPV and radiation, arsenic exposure. And like I said, there's different variants, and you can treat this with Mohs, excision, 5-FU, Aldera, ED&C, kind of depends on the site too. Okay, so this one. Now we have a proliferation that's going off of the epidermis into the dermis, and you have these kind of like larger, more pink keratinocytes, and they're forming keratin or it's like keratinizing. You have some parakeratosis. So this one is squamous cell carcinoma. So you have atypical keratinocytes that invade into the dermis. There may be desmoplasia, which is basically like fibrosis around it. There may be acantholysis. This is the second most common kind of skin cancer, second to basal cell, and the mortality rate is similar to that of melanoma, just because there's so many more squamous cells than melanoma. Um, and then there's some different subtypes. The high risk ones are poorly differentiated, desmoplastic, spindle cell, and the low risk subtypes are verrucous and KAs. So it's most commonly on the head and neck and dorsal extremities, like the dorsal hand. Oral SCC is most commonly on the lateral tongue. And then risk factors, a lot of like sun exposure, immunosuppression. It can be seen with some genetic syndromes. HPV increases the risk. Some conditions where there's chronic inflammation, like hypertrophic lichen planus or LSNA. TNF alpha inhibitors, some other medications like azathioprine, vismodegib, long-term voriconazole. And usually it's related to mutations in P53, and UVB can lead to thymidine dimers. And these tend to have a pretty high mutational burden. Okay, next one. So again, you see kind of like those pink keratinocytes, but the architecture is more verrucous. So this one is a verrucous carcinoma. So when it has like a more rounded border, this is low grade but can be really destructive locally. It's associated with HPV 6 and 11. And you don't want to treat this with radiation because it can lead to anaplastic transformation. So sometimes the question will be like, what are options? All of the following are options to treat this, except, and the answer is don't do radiation. So there's three main types. So it can be the plantar type, which is called epithelioma cuniculatum. It could be the Buschke-Lowenstein tumor, which is like a giant condyloma, or it could be oral florid papillomatosis, which is when you have multiple lesions in the oral cavity. Okay, so this one again has that glassy pink cytoplasm, or yeah, glassy pink cytoplasm, but it's also kind of cup shaped, and has like the central, I like to call it like a volcano kind of keratin. So this is a keratoacanthoma, which is a variant of an SCC. So these tend to have rapid growth and then they can involute spontaneously, but they don't always. And after biopsy, a lot of times they get bigger pretty rapidly. And it has the keratin-filled crater. It has the glassy red keratinocytes. You can see neutrophils and eos around. Um, and then you never see acantholysis in this. So there's some different variants and it can be associated with certain syndromes. So Ferguson-Smith and Grzybowski are like the two main ones. So Ferguson-Smith, you get rapid onset of multiple KAs in sun-exposed areas versus Grzybowski, you get hundreds of milia-like KAs in adulthood. Um, and you can get scarring, ectropia, and things like that. They're also associated with immunosuppression, HPV, and Muratori syndrome. And specifically with immunosuppression, you can get it with like BRAF inhibitors and some of the other kinase inhibitors. Okay, so this one, we see budding of basaloid cells coming off of the epidermis with peripheral palisading, but this is pretty much limited to the papillary dermis. It's not going deeper into the reticular dermis. So this is superficial basal cell carcinoma. And you also see distinctive fibromyxoid stroma that displaces solar elastosis downward. And you can see retraction artifact. This one doesn't really have a lot of retraction artifact. And this is more common on the trunk and extremities as compared to the face. And part of that is because that's like where, especially like on the back, that's where the collagen is thicker. So I like to think of it like the basal cell is having a harder time invading deeper because the collagen is thicker, and that might not be exactly like scientifically correct, but that helps me to remember it. Okay, next one. So in this one, we have more like islands of basaloid cells, and it's definitely going deeper down. You still see the retraction artifact, and you see the peripheral palisading, which is like them lining up at the edge. So this one is nodular basal cell. Um, and this is more common on the head and neck. Okay, next one. So this one looks pretty similar, except for the nodules are just smaller than in the last one. So this one is micronodular BCC, and this is kind of considered to be a more aggressive subtype, which we'll talk about. Okay, and then this one, you still have the fibromyxoid stroma, but now your islands are kind of more like branching. Some people say they kind of are like forming like a tree kind of structure. So this one's more phaeoform basal cells. So you get thin infiltrating strands of basaloid cells, sclerotic stroma, and then this is in your tadpole differential. So you may see like some tadpole-like islands with small horn cysts. And clinically, it's like a white to pink scar-like plaque, which is why they call it morpheoform because morphea is kind of like scar-like as well. Okay, so again, you see that this is a proliferation of basaloid cells, but it's really going deep and kind of like these little strands are going deeper down into the dermis. So this is infiltrative basal cell. They call it a spiky growth pattern. And you still have the fibroblast-rich stroma, not as much mucin in this one. And then you may see perineural extension or areas of squamous differentiation. Okay, last basal variant. So this one has thin anastomosing strands. So this one is a fibroepithelioma of Pingus. Sometimes you can see eccrine ducts within the strands, and it has a lot of fibromyxoid stroma, as you can see here. It usually presents as a pink, soft, fleshy papule or nodule on the lower back, and it's androgen receptor positive, BCL2 positive, and the stroma is CD34 negative, which can help distinguish it from a trichoblastoma. So now more about basal cell in general. So the most common mutation is patch, which is on chromosome 9q, and that's more common than the p53 mutation. This is the most common kind of skin cancer, and it's usually due to that intermittent and intense UV exposure. So the people that go to Mexico once a year kind of thing. And then also certain medications can increase your risk. High-risk subtypes are micronodular, infiltrative, morpheoform, and then some other high-risk features are like if the patient is immunosuppressed, if it's occurring in an area prior radiation or a prior basal cell, so it's recurrent, if there's perineural invasion, and then if they're bigger lesions as well. So nicotinamide, 500 milligrams twice a day can reduce the risk of SCC and BCC by 23%. So that's important to keep in mind. Okay, moving on. So here in the epidermis, we see these large cells that kind of look more clear. So these are Paget cells. So this is Paget's disease, and this is an intraepidermal proliferation of large cells with a lot of amphiphilic cytoplasm, so that more like clear kind of cytoplasm. And these can go up in the higher in the epidermis, which is why we call it pagetoid spread. And then they kind of like crush the basal cell layer, which you can see here. They're taking over that basal layer. So there's different stains depending on if it's primary or secondary. So we'll talk about that in a second. So first, Paget's of the breast. This is like an eczematous and or psoriasiform plaque of the nipple, and it's almost always associated with an underlying ductal carcinoma. So the next best step would be to get a mammogram or do further workup for breast cancer. And then extramammary Paget's disease. So it can be primary or secondary. This is usually like in the vulva or perianal area. So it's red and white macerated and eroded plaques. So primary is when it's just like in the skin primarily. So this is likely derived from Toker cells or cutaneous adnexal glandular epithelium. This is CK7 positive, GCFDP15 positive, and CK20 negative versus secondary is from an underlying GI or GU adenocarcinoma. And this kind of has like the opposite staining pattern. So this one's CK20 positive. So how I remember this is that we're all taught that METs, you're above the diaphragm is CK7 positive and below the diaphragm is CK20 positive. So when it's the direct extension from a below the diaphragm adenocarcinoma, it's CK20 positive, which is secondary. And you can treat this with Mohs and other things, but there's a high recurrence rate. So that's good to keep in mind. And then if it involves the perianal area, there's a 5 times increased risk of internal malignancy. And that is it. So we'll be back with another one soon. Thank you.